into our eating disorders here. The two major ones that we know, and we've probably heard from our society and television, is bulimia and anorexia. But there's also one called pica, and I call it pica. I'm sorry, it's called pica, but I call it pick at things, because pica means you're picking at your food. It doesn't really mean that you're consuming food. So they classify that as an eating disorder, but I'm not going to really cover that because there's really not a stress on that with nursing books as well as NCLEX books, and really what you need to know for your test. But as long as you can put that in your back pocket, let's not major in the minors here. Let's go after the big boys. So pica, remember, pick at things. There's picking at you. Bulimia. Bulimia is when your patients eat a lot of food, like gorge a lot of food, run to the bathroom, and then vomit it all up. So bulimia, I kind of remember that as bulimia. You get a bolus of food, a big scoop bolus of food. Now bolus is what we call a big thing of content. It can be fluid, like an IV fluid bolus, or it could be a bolus of food where you're choking on a bolus of food. Same thing here. We're eating a bolus of food, and then you're throwing it up. You're blowing it up in the bathroom, okay? You're throwing out of your mouth. So anorexia is the next one, and we're gonna cover both of these. Anorexia is when your patients do not eat because they have a fear of gaining weight. And remember, anorexia with an A. Because usually when you say something with an A first, it means without. So like amenorrhea, that means you go without your period. Anorexia means that you go without food or you're not eating, okay? So anorexia, that's how you remember it. So let's get into it here. So anorexia, like I just said, is that fear of getting fat, that fear of gaining weight, or that fear that I am way too fat, even though your patient's like really skinny. Now, to diagnose anorexia, usually we see this in a 15% weight loss. Higher than 15% weight loss, it's usually over time. Your patients will come into the hospital, and if their BMI is not where it should be, then we're going to diagnose your patient with some type of eating disorder. We'll interview your patient more, do all the labs, which we're going to get into, then we'll diagnose your patient, okay? So, they can do one of two things. Not eat food at all, or binge eat. And binge eat means that you do not eat food for a long time and then you just scarf it all in. Now, bulimia means that you're throwing it up. It's not anorexia. You scarf all that food, you can keep the food, or if you're throwing it up, that's when you get into bulimia. Patients sometimes have both, okay? Doesn't mean that you only have one or the other. You can have a chocolate or vanilla, or you can have a swirl, all right? That kind of deal. So there's an increased need for acceptance or an increased need for approval. And they've actually found that, obviously media and Cosmo and the type of that, like a woman should, the kind of figure they should have. They found that when the United States was going into Hawaii more back in the early 1900s to establish the what's it called, the Navy base, they found that a lot of Hawaiian women, obviously they're bigger set than most of the Caucasian Navy people. I don't know, sounds bad, I know, right? So a lot of the islanders, they were finding out, started having a lot of eating disorders because they wanted to emulate the Caucasians from the United States. And because with the United States, when they were basically taking over the society, we brought a lot of media too. So television and the way a woman should look and a figure should look. So just a little tidbit there for you. Maybe I didn't explain that correctly at all, but that's just a little bit of psychosocial, of needing acceptance, needing approval, altered perception of the body, which honestly, no one really makes up those rules. As long as you're healthy, you should be able to accept your body for the way it is. So don't let anyone tell you. And you're gonna have to educate your patients about this. That's what I say. Okay. So there is a deliberate weight loss. Deliberate weight loss with, actually I'm gonna move you guys over here real quick. There's a deliberate weight loss with your anorexia patients. Now, there could be throwing up, but it's not every single time. Every single time with bulimia, we have a binge scarfing of a bolus and then you throw up. Anorexia, not usually the case, could be sometimes, but not always all the time. That makes sense. So it's not bulimia, okay? Sometimes you could have both, but honestly, if your instructor is really just quizzing you on what you guys study, which usually never happens, right? Usually it should be black and white, okay, for the test. The big things here, you guys really should write these down here. The big things here are teeth problems. Because if your patient is malnourished, they're gonna have either deficits in nutrients, for instance, calcium, they'll get calcium deposits on their teeth, or if they're vomiting as a supplement, we will see yellow discoloration of the teeth because of all that gastric acid coming up the esophagus and burning the teeth. Again, usually we see that with our bulimia patients, okay? But kids see it with our anorexia patients. So you have discoloration of the teeth. With the lab values, you're going to have decreased CBC, your complete blood count, because your body's lacking iron. And remember, the factory that produces your red blood cells are in your bones, your bone marrow. And your bone needs certain vitamins and nutrients, like folic acid, mainly iron, to build these red blood cells. So without iron, without folic acid, we get anemia. Now it could be aplastic anemia, it could be pernicious anemia, which is in your stomach. Usually it always is pernicious anemia with your anorexic patients because they're not eating that stuff. So we give them B12 shots, we give them folic acid, we give them iron to get that CBC up, okay? Then next is your liver. Your liver might be off, so you're gonna have ALTs and ASTs increasing. You're gonna have increased enzymes from your pancreas, as well as decreased glucose, because we're not introducing sugars into your body. Your patient's not eating at all, okay? And remember, enzymes in your pancreas from Pirates of the Pancreas. If you guys didn't see that video, it's a really good one. But your pancreas secretes enzymes to break things down in your digestive tract. So, if we're not eating anything, you might have a lack of these enzymes, okay? So, other physical manifestations other than labs is your kidneys can have irreversible damage. So if we're gonna do a laboratory value on that, you're gonna have a high BUN. You're gonna also have a high creatinine level. Now remember, if you're dehydrated, you're gonna have a high BUN. You go on a marathon run, you'll have a high BUN. I'll have a high BUN. Remember, BUN is blood urea nitrogen. So it just means that you're dehydrated. You have burned buns. Now, if you have two that are increased, you will have possible kidney damage. That's really what alerts us to acute renal failure. And that's an entirely 4-part series. But irreversible kidney damage, okay? And one of the last phases here show changes. And this is because the body is trying to find fuel. After your body breaks down all of the adipose tissue, all the fat reserves, and it sucked all the glycogen out of your body, then your body goes after muscle. After it's taken a lot of the visceral muscle around your body, then it'll go after organ muscle. Because remember, the myocardium has a big, huge muscle in the heart. Myocardium, just heart muscle. So your body will actually, as a last line resort, take that as fuel to give itself life. Isn't that horrible? It's almost like, hey, you're stuck out in the wilderness, you have a pile of cash, and you have a pile of food, okay? Now, how are you gonna keep yourself warm? There's nothing really else to burn, so you start burning your cash. You start burning your clothes, right, to keep yourself warm. That's what your body's trying to do. It's a last line ditch effort to keep itself surviving, okay? This is anorexia, guys. This is without food. Now, on the other side of things, we have bulimia nervosa. Now, bulimia means that we are binge eating. And with binge eating, we are also binge throwing up. Remember, binge and bulimia and a bolus of food, always throwing up. So remember, your GI tract in your stomach, in your tummy, you have a ton of electrolytes sitting in there. And your big electrolytes are potassium as well as, sodium. Now, if your patient comes in for severe vomiting, let's just not even say it's bulimia. Let's just say they had a bad burrito, okay? They come in for severe vomiting. There are going to be hypokalemic. They're going to be hyponatremic. Usually, they're always going to be hypokalemic. Now, sometimes they'll be hyponatremic, okay? But you're talking about excessive vomiting a lot of times throughout the day. So definitely these two guys. Boom, boom. Obviously, fluid and electrolyte imbalances, because we know that these two bad boys sit inside the GI tract as well as a lot of other electrolytes. And that's what we really see in the hospital, okay? Now, some diagnostic procedures in terms of your patient's behavior. We see that they have secretive sneaking of food. Usually it's junk food. And they like to binge on junk food. And it almost sounds like nursing students, right? I mean, without the throwing up part, I hope. We like to binge on food, right? And eat everything that we tell our patients not to eat. Now, there's a decreased mood after purging. And purging means that we've taken in this bolus of food. It's almost like Casper, the Friendly Ghost, if you guys have ever seen that movie. And all these ghosts are like gathered around a table and they're just eating a bunch of just junk food, like cookies and ice cream, and it's like breakfast time. And they're eating it. And that's exactly what's happening here. There's a decreased mood after this purging, after this bolus feeding. And there's an increased mood when they are feeding. A feeling like they're in control of something and they're just, want that food. And then 30 minutes after, they will run to the restroom to throw up. So let's get into our nursing interventions here. Did someone say nursing interventions? All right, guys, so we're going into the nursing interventions here. So the big thing here in both anorexia and bulimia, both of them are really just psychiatric handicaps. So we have to rethink for your patients. We have to make your patients rethink the way they look at food. So one of the first things we do is cognitive behavior therapy. We have them do relaxation techniques, tell them to take the anxiety out of this loss of control with your anorexia patients. It's not about the calories, guys. It's about the loss of control and the fear. With bulimia, the same thing, but it's usually the joy of purging, or basically taking in that consumption of food. And they're both usually have this control type of aura about them. Now, we're going to give them relaxation techniques. Take the fear and anxiety out of eating. They can express their feelings in journal writing, and I'm going to say it again and again and again, because all your questions in psych, and usually all the test questions, are going to ask, how do you respond to a patient like this? Feelings. Get the feelings, man. Because really, we're just trying to get into the mind of your psych patients. That's all we're really trying to do. We're trying to gather data. Usually, we cannot cure your psychiatric patients because they don't want to help themselves usually. So we have to facilitate them reconstructing their own minds, okay? If that makes sense. So that's why psychiatric questions are totally different than med-surg. And usually if you're an A student in med-surg, you're not going to be a good student in psychiatric. If you're like a B student in med-surg, maybe you'll be like a B student in psychiatric. It just kind of has that offset. Now, you probably ace both of them just because you're awesome, but usually not the case. So, journal writing to express feelings, to gather data. Desensitization exercises, usually we use as a distraction for your patient. A way to get out excess anxiety. A way for them to feel like they're in control because they kind of feel like they lost control with the food deal, okay? Now, once we have this covered, actually not covered, but once we've initiated our brain psychiatric therapy, then we can move into the physical stuff. Because honestly, we can preach physical stuff all we want. If your patient doesn't realize how to rethink, they're going to go right back to the old ways they did. Okay? So, once we've figured out and kind of initiated the psychiatric care, then obviously we're going to take care of their physical needs. So, evenly spaced meals with correct calorie intake, also with high fiber, good amount of sodium, because remember, we're hyponatremic and hypokalemic. Same thing with our anorexia patients, very, very nutrient deprived, a lot of vitamins. And they're going to tell you, oh, you should have a varied diet or a well-balanced diet. That just means that we're getting an array or an assortment, almost like a flower bouquet of different kinds of foods. Because every single different kind of food has different vitamins and nutrients in it. So mainly vegetables, high fiber, usually all the stuff that nursing students are not eating, that kind of stuff. So high fiber, high fruits and vegetables, high vitamins, electrolytes to replenish the body. Okay, evenly spaced meals, your daily weights are your I&Os. Daily weights, we're measuring the I's and the O's, how much fluid your patient's taking in, how much fluid's coming out. What am I saying? Observe your patient and how much they eat at the table when you guys are eating. Usually we have staff members eat with the patients. Let me see if I can scoot you guys in here. So your patients will be eating, you're observing them, and if that's not like freaking their patients out enough, I don't know what is. But make sure, this is a great means to facilitate some therapeutic communication, right? You can ask them, how does that make you feel? How do you feel about this? Always gathering data. I guarantee you it'll be on your test. gathering data, guys. Okay? 1 hour after the meal, we are still observing the patient to make sure they are not throwing up. We are there to provide support, to provide encouragement. And that's what I wrote over here. You are not there to act like a dictator, even though there are nurses that, God bless their heart, but you just want to, give them one on the cheek, because they act more like security guards than really a supportive encourager, you know? So, they almost find it as like a punishment to be a nurse. Don't be that nurse, okay? So, encourage your patients, okay? Encourage them. Make sure that they feel you are on their team. You are there to help them. And one of the ways that it really works the best for encouragement is give them a reward if they did something good. So, if they did something great, you can give them more free time for something. I don't know. Give them their favorite movie. Usually try not to make it food-based. The risk and reward works really well. So, escort the patient to the bathroom. You have to make sure that it's within 30 minutes from the meal itself, okay? You are still observing the patient up to an hour after they eat, especially bulimia patients, guys. They are throwing things up. So you have to wait 30 minutes, then they can use the restroom, because your patient's gonna be like, oh, I have to use the restroom now. And it's like, yeah, but I know you're gonna throw it up, so no, okay? Another thing here, you can write this down, time limit on eating. Now it doesn't mean that they're eating. Usually it's for the bulimia patients to slow them down in terms of eating. So we'll extend a time for meal time. For your anorexia patients who don't eat, it's usually to give them a hurry up and eat time. So it's kind of offset a little bit. Now, make sure your patients are taking their medication for their psychiatric disorder here. Now, usually your patients will be on SSRIs. And remember that SSRIs are the yes sirrees, the Prozac, okay? If you guys don't know what I'm talking about, go look at the SSRI video. So that's it for the eating disorders. Let's go on to the next video, guys.